Hi there. Welcome to Doc Talk. As you remember, Doc Talk is the podcast that Knoxville Academy of Medicine records for your benefit to talk about health issues that impact all East Tennesseans. And we have a very important guest and friend who's joining us today to talk about something that has impacted every single Tennessean who's ever had a family member in a hospital. So this is a good one to listen to. I'm so happy. I'm Elise Denaney, former president of Knoxville Academy of Medicine, and I'm so happy that you're here to join me in welcoming Dr. Robert Montgomery with Summit Medical Group. Welcome, Dr. Montgomery.
Thank you.
Today we're talking about transitions of care. Okay, that's really kind of new and probably something that most people don't understand. So let's define that first. What is transitions of care?
Well, to start with, very often now when people are in the hospital, the doctor who takes care of them in the hospital and the doctor who takes care of them in the office are not the same doctor anymore. And we have hospitalists, and they see people who are sick, and they see people, and it's new to them. But when these people get to the end of their stay and they're discharged, then there's a transition. That transition is from the inpatient to the outpatient sector. Now, people no longer stay in the hospital until they're well. They stay in the hospital until they're ready to be taken care of on an outpatient basis. So it becomes critical that the care they get in the hospital be carried forward into the outpatient sector. And that's where our problem is. And we try and see that everything that's being done in the hospital is carried forward, but then all that information has to be transferred as well. And so anytime that a person goes from a hospital to a recovery center, to a nursing home, to an assisted living, or to their home, then that is a transition of care. And it's become a terribly important issue for all of us in trying to make sure that people continue to get well.
It's so hard. I mean, my mom and dad up in Chicago are almost 90. They will be 90. And so they've got their internist, they've got their pulmonologist, they've got their cardiologist, and then they get pneumonia. Okay, and they've got at least 5 or 6 medications. And I know for you, you have patients who you know so well. You know the ins and outs. You almost know how many times they blow their nose in a day. And then they go to a hospital because they're sick, or they go to the ER for a reason and they get admitted, and one, you don't know. 2, a brand new doctor's taking care of them who's never seen them before. And unless they are really, really sophisticated, which is hard at a certain age, knowing what medicine they're on, how much they're taking, whether or not it's going to interact with the new medicine the doctor in the hospital is going to put them on. That's just really hard.
Let's talk about some of the things that happen at that transition.
Okay.
That makes it a lot easier to understand. First of all, the person is discharged.
Okay.
Say they're going to go home.
Okay.
Number one, do they have a home? Do they have somewhere to go? And under what circumstances are they going there? So, in other words, does the person go home by car? Do they need an ambulance? Are they not able to ride in a car? And if they're going home, are they able to take care of themselves at home? Can they get out of bed? Can they put their clothes on? Can they take a bath? Can they prepare food? Is there some way they can get food into the home? Do they have an advocate to help them there? And that's just the going home part. And then there's, okay, so we're going to get home. Well, what are the needs of things that we have at home? Well, do you need a hospital bed? Do you need oxygen? Do you need a breathing machine? Do you need a bedside commode? Do you need home health to check in on you occasionally? And all these things create a level of complexity to which we come to the point of saying, okay, this person clearly can't go home. They can't get out of bed. How could they take care of themselves at home? And then they say, no, I'll be fine. Oh, I'm going to be fine. That's not a problem. I can do that at home. And you're like, well, no, you really can't. You've fallen 3 times in the hospital. We know you can't take care of yourself at home. So we run into this of deciding what are we going to do about it. And so that's when the idea of the nursing home, assisted living, the rehab center, whatever, comes into play. And that needs to happen long before the person gets ready to leave the hospital, though, or before the discharge time occurs. And then you come to the things like the medications. And so often the daughter gets a call. Mama says, I'm getting to go home today. So you go to the hospital. Well, Mama, what did they give you? Have you got medicines to take? Yeah, there's prescriptions here. And there's a whole stack of stuff for me to read. And I read about that one, and it's got a lot of side effects. I don't want to take it. Well, Mama, that's the one they've been giving you for the last 5 days. That's the one that keeps you from having a stroke. Oh, maybe I will take that. And then you go and you try and get the medications. Well, if people leave the hospital and they go to get their medications, well, first of all, do they have enough gas to get to the place to get sometimes that's even a question. And then beyond that, you go in and get the prescriptions and they say, that'll be $450. You say, well, I can't afford that. Or they say, well, this one has to be pre-certed and it's Friday afternoon. It'll be Monday before we can get in touch with your doctor's office and they'll be able to do the pre-cert to get the medication for you. And you run into this sort of thing. And medication holdup at the discharge level, it can be disastrous. The things that I've observed are this. If, for instance, you have diabetes and you can't get the insulin that's prescribed for whatever reason, if you have emphysema and you can't get the puffers, and I'm thinking about things that are expensive, if you have heart failure or you have an arrhythmia and you can't get the expensive blood thinners, or if you have an infection and the antibiotics cost more than you can pay for, your likelihood of being sicker and being back in the hospital within 3 days is extremely high. And so the transition of care has become a terribly important basket of things to help make sure that people's getting well goes forward rather than dropping back. And we find that there's so many ways that the whole thing can fall apart and the person ends up back in the emergency room and they're worse than they were off 2 days ago because they didn't get this or they didn't get that, or they've fallen at home, or they don't have the supplies they need, or they didn't need to go home in the first place. They needed to go to some other facility. And so that's caused us all to begin to look at transitions of care as a very important thing for us to study to decide how best to transition people from an in-hospital sector to an outpatient sector.
Would you recommend, I know I like to know, and I'm not even considered primary care, but I like to know if one of my patients has to be admitted to a hospital, because it matters to me. I want to make sure everything else is okay. And sometimes I see areas that I can streamline so they won't have a problem while they're in hospital. Would you recommend for your patients to notify you should they be admitted?
Yes, of course. Most do so. It's helpful if records are available. The CAT scan that was done last week really doesn't need to be done again just because you went to the emergency room. And availability of records is a problem that we have across the healthcare industry. Portability of records was supposed to occur with the Affordable Care Act and has not yet happened. Within a certain number of years, all the healthcare informational systems were supposed to interact so that a person could get their information from wherever when needed, and that hasn't occurred yet and still looks like it's going to be a very complicated thing to provide. And the complexity of some patients who have 4 or 5 illnesses, and let's face it, our population is becoming older all the time. And every 2 or 3 years you get older, you get a new diagnosis. So by the time you get 80, you've got a bunch of diagnoses. And with that probably goes several medications, and anybody who takes 5 medications is going to have some kind of side effect from something. Plus you go in the hospital and the medications may be changed. Mm-hmm. And then when you get out, and this is a big point of transition, what medicines are you supposed to take? Well, here's the ones they gave me in the hospital. Well, are they the same, any of them the same one that you have at home? Are they the same ones with a different name?
Very confusing.
Would you have known that warfarin, Jantoven, and Coumadin are the same drug, and if you took all three, it'd be fatal, you know? And you can't expect people to know that. That's beyond what you'd expect. The importance of an in-depth dialogue at discharge is so important, that transition occurs and that there be people who are able to help you with it. I think that everybody who's discharged from a hospital needs to have an advocate with them. I don't care if they're 12, 20, or 90 years old. Someone else with them who has a pad and pencil and can write down questions and write down things that they want to remember and ask questions at the time. And it's really important, I think, that they be there all at that same time. To come to get mother and, well, they've already been here and told us what to do and they're gone, that's set up for disaster. Doesn't need to happen that way. Even if you have to say, okay, I want to be there when the discharge occurs, about what time is that going to occur, or can you arrange a time that that's going to occur that we can all get together and talk? That really needs to happen.
Well, I love that you brought that up, the advocate, because I totally agree. If you're going to be in a hospital, you need to have a family member, a friend, or a loved one there with you. Even if you're 100%, even if you're a Rhodes Scholar, you know, when you're under stress, you don't remember things. So it's really helpful to have another set of ears. I've told patients, take pictures of your pill bottles so you have them on your cell phone. When I give them their reports of their CT, if they can't carry the paper around, I say, take a picture of it. You're always with your cell phone, and that way you can share it with your doctor. And what I don't know, I think transitional care is important enough that if they get discharged, if I discharge one of your patients, they get a follow-up appointment with your office in that next week, just to make sure the T's are crossed and the I's are dotted.
The other thing you mentioned about advocacy, I think it's terribly important, because even you and I not too long ago had cataract surgery. Mm-hmm. And I got back home and I thought, you know, I don't remember everything they said.
I know.
There's so much said and so much information, and you actually get information overload. That's you and I. Now, suppose if we're 80 or suppose you're just waking up from a procedure and they're going to send you home and you're still halfway asleep, that sort of thing plays into it. The other thing, though, is I think it's really important that people be proactive, that they not be just a receiver of health care, but they be proactive in, so what are we going to do after this? And that there be advanced planning. The day of discharge is not the time to do the planning of what's going to go on. There needs to be some looking forward from the day one of, you know, well, what's going to be the case at the end? What kind of shape are we going to be in? What are we going to need as far as follow-up? All that sort of thing needs to be addressed proactively. And if it is, the whole thing goes much better. And some of the things that you need to do, like home oxygen, a home breathing machine, these things take 2 or 3 days to get set up. You can't get that done in 2 or 3 hours at discharge. It just doesn't happen. So it's important that people be proactive about their health care as well, and ask questions and try and look forward and say, well, what are we going to be able to do and when do you think we're going to be able to leave, and so forth. And if somebody at the front end, and I've seen this a number of times with a hospitalist, which I think is great, and they'll say, okay, now the standard length of admission for this illness would be about 3 days. So that gives you a frame of reference to start with to say, oh, all right, so in about 3 days we need to be ready to go home. And if it doesn't work out to be 3 days, that's fine, but at least you have a frame of reference to start with. I think that's really good. But being proactive and having an advocate to help with, those two things are really important. Now, once you leave, though, some of the things we can do to prevent some of the disasters that occur. We, for instance, have a automatic policy that everyone who leaves the hospital, whether I'm taking care of them or somebody else is, when somebody that you say do surgery, for instance, they get a call from us within 48 hours with the list of all the medicines and the services that they need at discharge and whatever equipment and so forth they need. And they go over that line and verse with every bit of it. Did you get this? Did you get this? Did you get this? And then they create a document from that. And if there are gaps, then they'll bring that to our attention that they're not getting this, they're not getting that. What do we need to do? And then the follow-up appointments, a short follow-up appointment's important. If you, for instance, say, well, you need to see the patient within a week, okay, and they call the office and they say, well, they're going to be out of town until next month. We have an appointment in 3 weeks. There needs to be an understanding between physicians that if Dr. Denneny says they need to be seen in a week, they need to be seen in a week, and that visit will help prevent readmissions or deterioration, or the medicine's not working, or they've got the wrong medicine, or whatever. And it's terribly important.
I was thinking while you were talking, the fact when you were saying being proactive, being sick is kind of like taking on a team in a football game, and it takes every coordinator understanding if you want to win, you've got to share all that information and resources. And the family sometimes knows things that, well, mom can't go up that flight of stairs, just like you said. And we don't know that. We don't know that home situation, and it's great when the family can share that with whoever's planning.
That's the advocacy thing that I think is so important, because I think all too often I see people who have a greater opinion of what they are able to do than they actually can do.
We're pretty stubborn.
I'm gonna be fine. My neighbors will bring in food. I don't have to worry about that. And you say, no, Mom, you can't do that. And it's not just elderly people. It's the same thing for younger people too. We often have greater expectations of what we're able to do than what we're actually able to do.
Well, thank you. I think that's a great topic. So transitions of care is as important a factor in keeping you healthy as having the right medication.
Oh, absolutely.
And so, and it's a new concept, because when I trained in medicine, the person who was my GP went to the hospital if I had to go to the hospital.
That's right.
And that's all changed now. So,
well, in a changing world, it gives us great opportunity to figure out better ways to do things as we go along. For instance, that phone call that occurs that goes over everything, that's not from a doctor. We have a person who's trained to do that. They do a better job of it than I would, to tell you the truth. Mm-hmm. And then they get all that information to me, and we fill in the gaps. That's great. That's exactly the way it needs to be. And sometimes I find out they couldn't afford the insulin. And I'm like, oh, that person's going to be back in the hospital if we can't find them some samples somewhere. And sometimes I've had drug companies help me with that sort of thing too, to actually say, yeah, we'll provide you with if you need it.
Okay. So transitions of care, it is a team game, and we all play on that team to make sure that you win against any disease that may come your way, to you or to your family member. And thank you, Dr. Bob Montgomery, for joining us and explaining and helping us along that, and equipping us with the tools that help us to be better prepared for transitions of care. How do we get a hold of you if we have more questions in your office? Do you have an office number?
Yes. It's 531-4600.
Thanks, Dr. Bob.
Take care. Good
Thank
to see
you for joining us. And that's a wrap.